Good morning all. Today we are going to discuss about dentine hypersensitivity. This is one of the most commonly asked question for your university exams. So I would like to discuss these points under this heading: dentine hypersensitivity, definition, neurophysiology, theories of dentine hypersensitivity, etiology and prevalence, differential diagnosis, then management of dentine hypersensitivity. So just like the picture shows, it's a very sharp shooting pain, an excruciating pain that is denoted as dentine hypersensitivity under a certain condition. So coming to the definition, dentine hypersensitivity is defined as sharp short pain arising from exposed dentine in response to stimuli, typically thermal, chemical, tactile, or osmotic, and which cannot be ascribed to any other form of dental defect or pathology. So this is the definition given by Holland et al. 1997. Let's go through the definition once more. So dentine hypersensitivity is defined as short pain. It's a sharp pain and short pain arising from exposed dentine in response to stimuli, typically thermal stimuli, chemical stimuli, or tactile stimuli, or osmotic stimuli, and which cannot be ascribed to any other form of dental defect or pathology. This pain is sharp and short pain, but this cannot be attributed to any other form of dental defect or pathology. So that was a definition by dentine hypersensitivity given by Holland et al. Then before going to the details, let us see the neurophysiology of a little bit of neurophysiology. The dental pulp is richly innervated. According to conduction velocities, the nerve units can be classified into A group having the conduction velocity more than 2 meters per second and C group with conduction velocity less than 2 meters per second. The sharp, better localized pain is mediated by A delta fibers, whereas C fibers activation seems to be connected with the dull radiating pain sensation. So myelinated A fiber seems to be responsible for dentinal sensitivity. So the dentinal sensitivity pain is mediated by myelinated A fibers. Now let us go to the theories of dentin sensitivity. So basically you have three main theories: neural theory, odontoblastic transduction theory, and hydrodynamic theory. The first theory is the neural theory. It says that the neural theory attributes to activation of nerve ending lying within the dental tubules. These nerve signals are then conducted along the parent primary afferent nerve fibers in the pulp into the dentinal nerve branches and then into the brain. So this states that the activation of nerve ending lying within the dentinal tubules is causing the or mediating the pain. That is, the nerve fibers in the pulp transmits it into the dentinal nerve branches, and these transmissions are carried directly into the brain. So the neural theory considered that the entire length of the tubule contains free nerve endings whose activation or stimulation brings about this dentinal hypersensitivity kind of pain. So this is a schematic diagram showing the nerve endings within the dentinal tubules and the connected nerve fibers. So the activation of nerve endings associated with the dentinal tubules is carried into the brain. So that is neural theory. Now, the next theory is the hydrodynamic theory. This is considered as the most accepted theory nowadays. This theory proposes that a stimulus causes displacement of the fluid that exists in the dentinal tubules. So we know that there is a fluid associated within the dentinal tubules. So according to this theory, a stimulus causes displacement of the fluid that exists in the dentinal fluids. The displacement occurs in either an outward or inward direction, and this mechanical disturbance activates the nerve endings present within the dentin or the pulp. So there is a dentinal fluid associated within the dentinal tubules, whereas there are nerve endings present in the dentin or the pulp also. So whenever a stimulus comes, that causes the fluid movement that could be either outward or inward within the dentinal tubules, and this mechanical disturbance that is occurring within the dentinal tubules causes the excitation of the nerve endings present in the dentin or the pulp, which is transmitted to the brain as pain sensation. So this is currently the most accepted theory, that is due to the hydrodynamic fluid shift which occurs across exposed dentin with open tubules. This rapid fluid movement in turn activates the mechanoreceptor nerves of A group in the pulp. I have already pointed out that it is assumed that most probably the dental hypersensitivity kind of pain is carried by A group in the pulp. Now coming to the incidence and distribution of dentin hypersensitivity. The prevalence studies for dentin hypersensitivity are limited in number. The available prevalence data vary considerably, and dentin hypersensitivity has been stated to range from 8 to 30% of adult population. So the percentage of occurrence is 8 to 30% of adult population. This dentin hypersensitivity occurs. Most sufferers range from 20 to 40 years of age, and a peak occurrence is found at the end of the third decade. So most commonly affected age group is 20 to 40 years, and out of that, the third decade people are affected most commonly. In general, a slightly higher incidence of dentin hypersensitivity is reported in females than in males. The reduced incidence of dentin hypersensitivity in older individuals reflects age changes in dentin and then dental pulp. Because age changes means whenever the patient gets old or age, there is an associated, most of the cases, there occurs an associated sclerosis of the dentin, including of the dentin, the laying down of secondary dentin, and fibrosis of the pulp would all interfere with the hydrodynamic transmission. So there is a sclerosis of dentin and the fibrosis of the pulp also. So that interfere with the hydrodynamic transmission of stimuli through exposed dentin. Coming to the intraoral distribution. Hypersensitivity is most commonly noted on buccal cervical zones of permanent teeth. One of the reasons could be due to the increased toothbrush abrasion causing exposure of the dental tubules and the root dentin. Although all tooth type may be affected, canines and premolars in either jaw are the most frequently involved. So canines and premolars in either jaw are most frequently involved. The reduced incidence of dentin hypersensitivity in older individuals reflects age changes in dentin and the pulp. This we have discussed already. Matthews et al. Noted that such as the stimulus such as cold causes fluid flow away from the pulp, produces more rapid and greater pulp nerve responses than those such as heat, which causes an inward flow. So Matthews et al. Says that actually the stimuli that resulting in dental hypersensitivity due to cold is more sharper and pronounced than heat. The reason what they cite is that cold stimuli causes an outward flow of dental fluid movement, whereas the heat causes an inward flow of fluid. This certainly would explain the rapid and severe response to cold stimuli compared to the slow dull response to heat. So When it's covered, the outward flow of fluid is causing the more severe and sharp pain. The dehydration of dentin by air blasts or absorbent paper point causes outward fluid movement and stimulates the mechanoreceptor of the odontoblast, causing pain. Prolonged air blast causes formation of protein plug into the dentinal tubules, reducing the fluid movement and thus decreasing pain. The pain produced when sugar or salt solutions are placed in contact with exposed dentin can also be explained by dentinal fluid movement. So again, the same feature is coming here. When sugar or salt solutions are placed in contact with exposed dentin, there's an associated pain in such individuals. The reason is again cited that the similar one, just like the cold stimuli. That is, the dentinal fluid is of relatively low osmolarity, which have tendency to flow towards solution of higher osmolarity, that is salt or sugar solution. So when a salt or sugar solution is placed onto the dentinal surface, exposed dentinal surface, there is an outward flow of movement, which is more vigorous and causing more sharper and severe pain. These images, the first one, top picture shows effect of air blast on dentin, blast of air or causing dehydration. The second one causes cold stimulus, how it's acting. Then heat compares with heat stimulus. Cold causes an outward flow of fluid, whereas the heat causes an inward flow of fluid. Then the last one shows the hyperosmotic solutions like sugar and salt solutions causes a similar fluid movement just like the cold stimulus. Now coming to the etiology and predisposing factors. The primary underlying cause for dentin hypersensitivity is exposed dentinal tubules. Dentin may become exposed by two processes, either by loss of covering periodontal structures, that is occurring in incidence of gingival recession, or by loss of enamel. So it's very common and cases that whenever there is a loss of enamel, the underlying dentin is exposed, or due to gingival recession, when the root surfaces are exposed, the root is made of, outer portion is made of dentin, so dentin is exposed. The most common clinical cause for exposed dentinal tubules is gingival recession. Most common clinical cause for exposed dentinal tubules is gingival recession. Various factors which can cause recession are inadequate attached gingiva, improper brushing technique. So all these can cause gingival recession. Periodontal surgery, overzealous tooth cleansing habits, that is excessive pressure applied during brushing, oral habits, etc. All these can result in gingival recession. Now coming to the common reasons again for gingival recession: inadequate attached gingiva, prominent roots, toothbrush abrasion, oral habits resulting in gingival laceration, that is traumatic tooth picking, eating hard foods. All these can result in gingival recession. Excessive tooth cleaning, excessive flossing, gingival recession secondary to specific diseases, that is NUG, necrotic ulcerative gingivitis, periodontitis, herpetic gingivostomatitis, as well as crown preparation. So again, crown preparation can also expose the dentinal tubules. Reasons for continued dentinal tubular exposure: poor plaque control, that is acidic bacterial byproducts. This can expose more dentinal tubules. Excess oral acids consumption like soda, fruit juice, swimming pool fluorine in coming in contact with the tooth, bulimia, etc. All this results in dentinal tubular exposure. Then cervical decay of the tooth, toothbrush abrasion, tartar control toothpaste. So all these things, factors cause dentinal tubular exposure. Now the reason for exposure of dentinal tubules is due to another reason for exposure of dentinal tubules is due to loss of enamel. Let us see what are the causes of losses of enamel. Loss of enamel: attrition by exaggerated occlusal functions like bruxism, abrasion from dietary components or improper brushing technique, erosion associated with environmental or dietary components, particularly acids. So all these things, attrition, abrasion, and erosion, all these can cause loss of enamel, leading to exposure of dental tubules. So is one such incident related to gingival recession, you can see that gum loss exposing dentin. Due to the recession, the root is exposed, exposing the dentinal surfaces. And the first molar here, there is an associated small carious lesion on the buccal surface of the crown, exposing the dentin. In both these incidents, it can occur. Likewise, there are in this picture image, you can see the wear facets on occlusal surface of molars, causing loss of enamel and dentinal exposure. Now coming to the differential diagnosis, what are the conditions that can mimic the condition of dental hypersensitivity? Cracked tooth syndrome. First one is the cracked tooth syndrome. Then reversible pulpitis. Reversible pulpitis, tooth hypersensitivity differs from dentinal or pulpal pain. So you have to note that all three above, it's a pulpally involved, direct pulpal involvement is there. Whereas the tooth hypersensitivity differs from dentinal or pulpal pain. In case of dental hypersensitivity, patient's ability to locate the source of pain is very good, whereas in case of pulpal pain, it is very poor. So in most cases, patient is able to locate the source of pain. So that's a very characteristic feature of dental hypersensitivity when we compare with that of pulpal pain. Pulpal pain is not easily located by the patient, whereas dental hypersensitivity is easily located. The source located where the source of pain is coming from. Now let us see the treatment of dental hypersensitivity. So again, this can be divided into home care with dentifrices, in-office treatment procedure, patient education. So this flowchart basically summarizes the management of dental hypersensitivity. First one is home care with dentifrices, strontium chloride dentifrices, potassium nitrate dentifrices, fluoride dentifrices. All these dentifrices used in home care can reduce dental hypersensitivity, mild cases. In-office treatment procedures, the second one is in-office treatment procedures where the dentist performs some procedures. These are application of varnishes, corticosteroids, treatments that partially obturate dental tubules. This includes burnishing of dentin, silver nitrate application, then zinc chloride, potassium ferrocyanide application, then formalin, calcium compounds like calcium hydroxide, dibasic calcium phosphate, then fluoride containing compounds like sodium fluoride, sodium silicofluoride, stannous fluoride application. So all these things can reduce dental hypersensitivity by partially obturating or occluding the dental tubules. Next treatment strategy is by iontophoresis, then strontium chloride, potassium oxalate components. And the next one is applying tubule sealants like restorative resins, dentin bonding agents. The next one is miscellaneous, that is under which you have the laser treatment. Then the last one is, apart from home care and in-office treatment procedures, last one is patient education by dietary counseling, asking or giving advices on what are the foodstuffs to be avoided or what are the dietary habits to be changed by a dietary counseling, like avoiding of these beverages like carbonated beverages which causes excessive erosion of the tooth, and toothbrushing technique, advising proper toothbrushing technique. So this avoids excessive application of force on the tooth, thereby causing enamel loss. So this can be reduced. Then plaque control, proper plaque control measures. So this includes patient education. Now criteria for selecting desensitizing agent: provides immediate and lasting relief from pain, and it should be easy to apply. It should be well tolerated by the patients, it should not be injurious to the pulp. It should not stain the tooth. It should be relatively inexpensive. Dentifrice with formulations of strontium chloride 10% and potassium nitrate 5% are also used. Now coming to the varnishes application and corticosteroid application. Open tubules can be covered with a thin film of varnish, providing a temporary relief. Varnish such as copalite can be used for this purpose. For more sustained relief, a fluoride containing varnish duraflow can be applied. Next one is corticosteroids containing 1% prednisolone in combination with 25% parachlorophenol, 25% methacryl acetate, and 50% gum camphor was found to be effective in preventing postoperative thermal sensitivity. The use of corticosteroids is based on the assumption that hypersensitivity is linked to pulpal inflammation. Hence, more information is needed regarding the relationship between these two conditions. So, the idea of using corticosteroids is based on the assumption that hypersensitivity is linked to pulpal inflammation. So, this relationship between pulpal inflammation and hypersensitivity is still to be researched. So, the studies are going in that direction. So, the assumption has to be studied further. Vernishing of tendon with orange wood sticks results in formation of a smear layer occluding the tubules. Then application of fluoride compounds, APF gels, sodium silicofluoride, stannous fluoride, all these precipitates calcium fluoride crystals on dental tubule surfaces, occluding them. Now, fluoride iontophoresis. This is a very important treatment strategy. Iontophoresis is a term applied to the use of an electrical potential to transfer ions into the body for therapeutic purposes. So, it basically involves the transfer of electrical potential to transfer ions into the body for therapeutic purposes. The objective of fluoride iontophoresis is to drive fluoride ions more deeply into the dental tubules. So here the idea is to drive fluoride ions more deeply into the dental tubules. That cannot be achieved with topical application of fluoride alone. So wherever topical application of fluoride alone will not give you enough results, sufficient results. So this one is tried fluoride iontophoresis by driving fluoride ions more deeply into the dental tubules and occluding them. Now coming to the formation of insoluble precipitates to block the tubules. Certain soluble salts react with ions, such ions into structure to form crystals on the surface of the dentin. To be effective, crystallization should occur in 1 to 2 minutes, and the crystals should be small enough to enter the tubule and must also be large enough to partially obturate the tubule.